Hello everybody and welcome to this workshop on the challenge of culture change in the NHS. My name is Michael West. I'm Professor of Organisational Psychology at Lancaster University and Senior Visiting Fellow at the King's Fund in London. And I'm delighted to be joined by presenters in this workshop who I will introduce as we go through. We have 3 presentations and then the opportunity for discussion. The NHS has been through extraordinary times in recent months, but even before we began to experience the tragedy and the extraordinary changes of this pandemic, the NHS was already in a crisis state with very high levels of vacancies, the highest levels of staff stress since we have been recording them, and huge numbers of staff leaving the NHS because of the conditions they found themselves working in. There were also serious declines in the quality of care that was being provided and the speed with which care was being provided. And so this workshop addresses hugely important issues. I'm delighted to introduce our first presenter today, Professor Graham Martin, Director of Research at the Healthcare Improvement Studies Institute at the University of Cambridge. Graham, over to you.
So thank you, Michael, for that introduction. I suppose I will be extending the introduction in some ways with my presentation, and I'll be starting by giving a bit of a background to the policy that has given rise to a lot of the recent changes and which itself responds to some of the issues and challenges that Michael mentions, starting with the Mid-Staffordshire inquiry. I'll give a very brief introduction, a very fleeting introduction to the literature, the academic literature on culture change more broadly. And then I'll spend the bulk of the presentation giving some key findings from a recently completed policy research programme funded study on efforts to implement policies that try to affect the culture of openness in the NHS following Francis. And I'll be talking in particular about 4 seeming necessary conditions for cultural change, which don't necessarily promise cultural change, but which do need to be in there to underpin it, and 4 enduring challenges that NHS organisations face in trying to change culture. So I think even now, the Mid-Staffordshire inquiry probably needs very little introduction. Came out of the very wide-ranging challenges in the culture of care and the quality of care at Stafford Hospital. Famously, of course, the Francis inquiry that followed had a very large number of recommendations about improving care across the NHS, not just at Stafford, some 290 in all. Those were very wide-ranging and covered a whole range of different issues. There was no one root cause, but I think it's fair to say that Francis did identify culture as being a really fundamental challenge in all of this, both in the problems that arose at Stafford and elsewhere, a culture focused on doing the system's business, and in the potential solutions to those, fostering a common culture shared by all in the service of putting the patient first. There have been other scandals and other inquiries and other policies since then. Those similarly tend to emphasise culture as both a problem and a solution, whether that's at Morecambe Bay or in terms of investigating serious incidents or anything else. So culture is identified as being important, and that's not unique to healthcare. The culture of organisations is seen as fundamental to performance across sectors. It's also something that's rather intangible. It tends to be defined in terms of the way things are done around here, particularly when nobody's looking. The things that are done in practice habitually, routinely, all of the stuff that goes beyond the pages of policies. And for that reason, because it's so fundamental and because it's essential to an organisation, it is seen as fundamental to organisational performance. There's lots of well-known aphorisms in this regard, this notion that culture eats strategy for breakfast. You can make as many strategies as you want, but if you don't address the culture of an organisation, you're not going to get anywhere. And for those reasons, it is the art of changing culture is seen as key to success. But also for those reasons, changing culture is very, very hard, particularly if we see culture as something that an organisation is, all those routines, habits, things that go on without people being even aware of it unconsciously, rather than something that an organisation has. You can change an IT system, you can change an HR policy. How on earth do you go about changing a culture? You can only do so at best indirectly. Nevertheless, as I say, a lot of the policies that followed from Mid-Staffordshire and other crises in the NHS have tried to do that exactly. They've all had more proximal objectives. So things like, for example, the duty of candour seeks to address openness with patients and families following serious incidents. The Freedom to Speak Up programme seeks to provide opportunities for people to to identify issues and to ensure that those are addressed. But they also have this wider aim of trying to address culture. And this is what we were trying to get at with our PRP funded programme. Because of the nature of this presentation, because I don't have very much time, I won't be able to show you the working of this in any great detail. Here are the methods in summary. I'll be focusing in particular on the second case study-based package of work, which looked at 6 organisations, 3 acute trusts, 2 mental health and community health services trusts, and 1 ambulance trust, and the way in which they tried to implement various policies that have followed on from Francis. They were all interview-based, and that, of course, brings its limitations, but they were quite wide-ranging in their approaches. We managed to get the insights of a good range of staff, and for that reason, I think they do have some value in indicating those conditions that can encourage and inhibit at least the possibility of cultural change. So, as I say, I'm going to now focus on 4 aspects that cut across the organisations. 4 seeming necessary conditions for cultural change, and then 4 challenges which were similarly endemic across the organisations that we looked at. So necessary condition number 1, functional administrative systems. It's fair to say that bureaucracy often gets a bad name. It's not necessarily very fashionable, but nevertheless, high quality administration was essential. Not least because these policies were very complex. They involved coordination across a lot of groups. They had quite a heavy audit and monitoring burden. And so simply putting it into practice well required a lot of careful planning, high quality systems to deliver that, and integration across different people involved. And the quotation on the left there perhaps shows quite the level of complexity involved in doing this well. And certainly it was very clear in some of the organisations we looked at that a great deal of investment and time, senior resource had gone into this, into making the systems function as well as possible. Conversely, in some of the other organisations, it was clear that this wasn't necessarily the case. So organisations that had put a great deal of effort into this over time, into trying to ensure that their systems delivered the openness policies effectively and efficiently and in a way that could be audited. This made a big difference both to the ability to show that they were delivering these policies effectively, but also to their ability to do them effectively and to ensure, for example, that learning from different aspects of policies, be they serious incident investigations, the duty of candour, freedom to speak up, were integrated and used effectively to identify areas where openness was a problem and to try to intervene to improve it. Second cross-cutting theme is around almost the opposite to that point around functional administration, but not entirely the opposite. So good administrative systems clearly are essential to delivering these policies effectively, but they're a necessary and not sufficient condition. And in fact, actually being able to at times work around those administrative systems was also important. The heavy monitoring and accountability framework of the initiatives meant that sometimes for people who were at the sharp end experiencing them, be they members of staff who were speaking up or patients or families who were receiving disclosure, almost could feel as if the system and the administration of it was taking precedence over their own needs. They experienced what we've characterized as coldly bureaucratic systems that pushed on very effectively in delivering policies, but without any sensitivity to the people involved in this, who ultimately perhaps were the beneficiaries, and without any flexibility in trying to tailor those processes to the people involved. This was problematic in particular because sometimes it could give the impression that this was a system that was purely focused on delivering the policies for its own sake, rather than something that was oriented towards openness as an end in itself. These 2 quotes that I present here, the one on the left comes from a member of staff, the one on the right comes from a patient. But I think there's a fascinating symmetry between them, because they were both people who had dared to speak up, who had tried to challenge the system, who felt that there were injustices in place and tried to do something about it. They were both people who went into that process with a view to trying to improve the quality of care, trying to improve openness and to get answers to questions that were not, they felt, not being answered. And in both cases, what they found was that the system ground on and really just didn't fit their queries, started to alienate them, set them up as adversaries rather than people who could cooperate in trying to improve openness. And this created systems that felt much more adversarial in terms of what they tried to do rather than inquisitorial. And I think the fascinating thing about these quotes is quite how symmetrical they are. This applied equally to people inside, ostensibly inside the system, who could also be left drained, feeling that this was, you know, a process for its own sake rather than a process that was oriented towards improvement, and people outside the system all the more so. Third necessary condition is around the integration of these processes into the wider organisational mission. There's a very palpable difference between our case study organisations, between those that seem to have implemented the policies in a very bolt-on way, grafted onto what was already there, basically little thought to how they aligned with and integrated with existing policies and practices, and those that tried to integrate them fully, to make them a part of the mission, try to make them a part of business as usual. I'm going to illustrate this through the contrasting experiences of a couple of freedom to speak up guardians in two organisations, one of whom had dedicated time, who had support, administrative support, who had funding, and who was basically supported to really achieve their role very effectively, had the time and the space to do that, to raise awareness, to encourage people to speak up, endorse and sponsor the programme, versus another in a different organisation who had very, very little time dedicated to this, who had no support, and who really was reduced to little more than a photo on the wall or a screensaver. So you can see how these different approaches to implementing freedom to speak up would affect the ability of the guardians themselves to carry out their duties. More than that, though, it was crudely obvious to people at the sharp end of organisations how much or how little their organisation valued openness and really did see it as central to their mission on the basis of these kinds of signals. It was very clear when something was being grafted on was really something that was being done reluctantly, something that was on the side of the organisation, versus something that was really being taken seriously, that was being invested in, that was being made central to the organisational mission. And this had to take place not just through implementing the policies, but also thinking about wider frameworks for example, around accountability, around behavioural expectations, around values. And again, the organisations that seemed to be making more progress here had done a great deal of work to integrate the policies and to think about how they articulated with these wider aspects of organisational mission. Finally, all three of these prior necessary conditions were underpinned by a fourth, which was really a commitment to ongoing learning and improvement, and setting up the kind of administrative systems that could execute those responsibilities around openness well, and putting openness front and central in organisational mission. These weren't things that happened overnight, and these weren't things that were easy. These were things that were actually delivered through an ongoing process of trial and error and improvement. So a lot of this work required really long-term investment. It was often, in many of the organisations, or in some of the organisations we looked at, prompted by specific local incidents that had caused reflection and which had led to these issues being taken seriously. To do this properly, these policies had to be treated not as time-limited projects to be managed through to completion, to have outcomes delivered and then signed off. Project management was very important to delivering them, but they needed to be more than that. They needed to be an ongoing part of the organisation's fabric. And I think this is something that might be picked up in some of the other presentations and in the discussion later on. So delivering these policies well meant seeing them as more than policies, seeing them as more as time-limited projects to be delivered, and rather something that was never going to be completed, that had to be carefully managed, but which also had to be seen as a long-term, open-ended, changing set of goals and practices. So that's a whistle-stop tour of some of the conditions that we saw in some of the sites, which seem to be prerequisites for cultural change. As I said right at the start, this isn't necessarily about culture change in itself, and certainly we can't with any confidence on the basis of this relatively cross-sectional rather than longitudinal research say whether culture change was taking place and catching on in these organisations. But I think what we can say is, first of all, that an awful lot was in the detail of implementation, that simply putting these policies into practice in a relatively top-down way looked likely to achieve very little. We can also say that the impact of these policies seem to be patchy even within organisations, and even in those organisations where progress seemed to be being made, there was much talk about the heterogeneity, really, the varied organisational topography, that meant that some parts of the organisation were much easier to access, seemed much more amenable to change, whilst other parts seemed quite remote and caused sleepless nights for those people who were responsible. Nevertheless, what I think we do have from these findings is a sign, at least, of what can make a difference. Some evidence that there are sustained ongoing efforts in organisations, and this comes from the rest of our research, that do seem to be sticking, that organisations are persisting with. And often these actually predated the Mid-Staffordshire report and were instigated by local issues that had caused local action. And I think we can also say that maintaining that focus and mainstreaming this activity is really, really crucial to the sustainability of these policies. It was very easy for them to be seen as things to be done and then put to one side. And we did see that in some of the organisations, and we saw the consequences of that, as I say, particularly for people at the sharp end who could, it was very transparent to them whether their organisation was taking this seriously or not. So I think some signs for cautious optimism there, and at least some signs of what the necessary conditions might be for the possibility of sustaining a culture of openness in the long run. Finally, and perhaps slightly more negatively, I'm going to speak very briefly to 4 enduring challenges, which again were reflected to varying extents across the 6 organisations that we looked at and in the wider research programme. First of all, an awful lot of these policies, even the mandated ones, were reliant for their implementation on the goodwill and the discretionary efforts and the unpaid labour of staff. And as Michael alluded to at the start, we've already seen the toll of COVID-19, not just on patients, but also on staff in organisations, on their well-being, their mental and physical health. But this isn't new. This hasn't arisen just with COVID-19. There have been for a long time challenges, I think, within the healthcare system for people in terms of morale, in terms of how they're valued, in terms of overwork, in terms of burnout. And this does pose this reliance, continued reliance on that kind of discretionary effort from staff does pose a challenge to sustainability, particularly if it seems to be a one-way street where it's all about giving on the part of staff at the sharp end and they can't see the benefits of that. Secondly, again, a lot of this effort was premised really on what we've called an ethos of organisational development. That's to say, a notion that the best way to develop an organisation is by investing in the staff, in using their skills, relying on their motivation and their goodwill to achieve things. And a lot of the time that works very well. But again, in all 6 organisations, there were corners where that kind of approach just seemingly hit a brick wall, whether because of individuals who were resistant to it, people who just didn't get it, corners of the organisation where there were domineering personalities and fiefdoms. Sometimes this enlightened, should we call it, approach to trying to encourage openness just didn't work. And I think in some cases, a more disciplinary approach is undoubtedly needed. But in itself, again, is an enormous bureaucratic and administrative undertaking if you're going to do it right and if you're going to do it properly. Third, and picking up on the first point, I suppose, the burdens of speaking up are well documented in terms of whistleblowers. We know how many whistleblowers in the NHS and around have been castigated, but it's not just whistleblowers who can suffer for speaking up about concerns. This can also happen, we saw in the case study sites, on a much more mundane level. Simply voicing concerns or saying that something isn't quite right could result in really quite unpleasant consequences for the people doing it, being moved on, being ostracized, experiencing informal retaliation from colleagues who feel threatened, and for patients as well who raise concerns, who are fobbed off, who are made to feel unreasonable, who are simply lied to. And there does need to be an investment to support people who speak up and also to show that that support is there. And then finally, there's a curious gap, I think, in what we found in the research and perhaps in the policies. There's been an awful lot of activity since the Francis report around enabling staff to raise concerns, to try to initiate openness, be that freedom to speak up or various other activities. But if you're a patient or a carer who thinks that there's something amiss, then actually the avenues open to you to raise those concerns don't look too very different from how they looked 10 or 15 years ago. It's surprising perhaps how little attention there has been to allowing patients and families to raise concerns compared to the attention that's been given to staff, particularly when you consider Francis himself lauded informal efforts by patients and organised groups of patients, Cure the NHS and others, to raise the alarm at Stafford, when you consider how patients and carers have been really instrumental in exposing problems elsewhere. And yet these policies still, by and large, seem to position patients and families as beneficiaries rather than active agents in this. There were some local examples of how organisations have tried to help patients to raise concerns and speak up, but on a national level, that's a lack, and I wonder if there is perhaps some learning to be done there to scale up from those local initiatives. So thank you very much for listening. This is a PRP funded study, and so we are including the appropriate acknowledgement and disclaimer that these views are our own rather than necessarily those of our funder or anyone else. Thank you very much for listening.
Thank you, Graham, for giving us insights from staff into the culture of our NHS organisations, particularly in the context of where things go wrong, and therefore what we need to focus on in terms of creating cultures where those issues can be addressed in a sustainable way. Our second presentation focuses on the experience of patients, and I'm delighted to introduce Professor Naomi Chambers, Professor of Healthcare Management at the University of Manchester, and Jeremy Taylor, who's director of the NIHR Centre for Engagement and Dissemination, who will give us perspectives from the learning that comes from speaking with patients. Thank you.
Thank you very much, Michael. And I want to pick up in this presentation a little bit about of what Graham has said. I'm going to be talking about the challenge of culture change in the NHS, learning from testimonies given by patients, which forms the cornerstone of a book that is coming out next year to be published by Manchester University Press. So I'm going to talk for about 5 minutes, and then I'm going to hand over to my co-author, Jeremy Taylor, to talk in particular around the experience of asking and listening to patients. So I'm going to explain a little bit about the background to the forthcoming book, the place of storytelling in health service research, the experience of asking and listening, and what we found during the process appears to be important to patients. And it's that which provides, I think, a very strong, close link to what Graham has been talking about, particularly around the troubling continued marginality of patients, carers and families that he spoke of. So the working title for the book is going to be Organising Care Around Patients, and it's to be published by Manchester University Press next year, and we are the two authors, although we should say that most of the book actually is testimonies from patients themselves and from carers. And the purpose of the book is to generate insights into how to provide care that is more patient-centred. And the main content of the book is a collection of around 20 narratives from birth up until the end of life about what it's like when services get it right and when they get it wrong, in order to provide an immersive experience, and we'll touch on that a little more, and also paint a rich and varied picture. And in constructing the format of the book, we have been influenced by a number of texts, but particularly these two I mentioned, which are not healthcare focused texts, but have been powerful influences for us. I don't know how many people are aware of Svetlana Alexievich's work. She's a Russian journalist and has recorded huge numbers of interviews around a number of stories, one of which is the Chernobyl disaster, which we reference here. And then also Wendy Perlman's work, listening to voices from Syria about the Syria catastrophe, which puts actually our first world woes around pandemic and indeed even the NHS in some kind of context when you hear about how a whole nation has been affected by the civil war in Syria. But both of those are, if you like, mosaics or montages of people's testimonies. A little bit of background around storytelling in health service research. There are a number of authors that talk about the importance and the centrality of storytelling, and beyond the healthcare context, there is a notion that, in fact, the way in which we make sense of the world is through listening to each other telling stories, and ourselves telling stories to make sense for ourselves of what has happened. So Storr's work is very influential in that regard. Stories are everywhere, stories are us. In the preamble to the recording for today, those of us presenting today told a few short stories about what, the context for us as of this morning, as of the 5th of June 2020. But in addition to that, there's a line of argument around the importance of serious storytelling to achieve serious goals. So storytelling is about entertainment, it's about ensuring that myths are recorded and handed down to different generations, but they're also about achieving serious goals. So Graham, for example, mentioned Cure the NHS, and the referenced Julie Bailey's work in terms of bringing the failures of care at Mid Staffordshire NHS Trust to light. And there have been a couple of very powerful programmes on TV that told that story, and that's an example of serious storytelling. I like this one from William Osler, and just listen to your patient. He is telling you the diagnosis, which is, I think, a lovely phrase when we are perhaps not listening as well as we might be. And then turning now to health service research more distinctly, influential researchers such as Trish Greenhalgh and Wengraf have now written quite considerably about the importance of the narrative method, sometimes in mixed method studies and employed by researchers such as Graham and myself and many, many others. But Greenhalgh and Wengraf talking about the narrative method having acquired legitimacy as a decent form of health service research. And then finally, the potential of storytelling to facilitate culture change and greater humanism in healthcare, which is very much the focus of today's workshop. And that work by Rose is a literature review looking at qualitative methods and particular eliciting stories and the impacts of those in terms of fostering greater humanism in healthcare. In a moment or two, I'm going to be handing over to Jeremy to speak a little bit more about this, about the experience that we have had over the past 12 months or actually longer of asking and listening to patients. And so I'm going to focus on particularly on the last of those phrases, which was that actually, first of all, as the listener, and then as the reader, and then finally as the editor. So we will have worked with these stories at least 3 times, but probably 4 or 5 times by the time the book actually goes to print, it is impossible each time not to be moved and affected by some of the stories. And I'll give you 3 examples, and Jeremy and I are in constant communication about as the book is shaping up. But I remember Jeremy saying at one point in connection with one of the stories where I'd done the interview that he didn't get through it without welling up, because he was affected by what it actually not in a, it wasn't a catastrophic story. It was a moving story, and it was impossible not to be moved. And I've got 3 examples where I've had to work with one particular story 3 times in editing it, and each time I forget that I am going to be affected, and by the end of it I actually feel sick. And it's the story of a woman who actually in the end says, you know, things went badly for me, but it was because of, you know, clinically just a kind of combination of events, which meant that when she gave birth, she managed to get sepsis twice. I mean, it's absolutely extraordinary. Ended up with an emergency cesarean section and ended up also with the wound coming open when she'd been discharged home. By the end of the story, each time I feel physically sick, but a bit like being on a car journey when you're about to be travel sick. You don't know that it's happening until it kind of just comes over you. So that we're hoping that the whole book will be that immersive experience and gripping, but not, I hasten to add, in a kind of disabling way, but in a moving way. And we think that immersive experience is really important. It's quite clear to us from reading and rereading the stories that there are probably around 5 enduring themes that come out, and it's interesting how close they are to what Graham has been talking about, and they're not new to us, but we do want to explain how they are 5 parts of a whole. That's really important. And we talked, and Francis has taught, and over the last 8 years we've talked a huge amount around the importance of kindness and compassion. And that comes through very strongly in these stories. So in the second example of a story that very moved me, and I did carry out this particular interview, this woman is looking after her mother who has early onset dementia, and the family is a Muslim Asian family and encounters many examples of discrimination which are hard to listen to but must be much harder to bear. And halfway through the story, she talks about a visit to the physiotherapist that has been very difficult to organise because her mum with dementia and with no English struggles to make it to those kinds of appointments. But they finally get to the appointment, and the physiotherapist says to the woman who is caring for her mum, "How are you?" And immediately the woman thinks that this is a question where she has to translate into her mum's language that question. And the physiotherapist actually means, "How are you?" as the carer, "How are you?" And in all that time, nobody has asked her that question. So it's not about translating it into language that her mother can understand. It's actually directed at her as kind of an example of kindness in the middle of all the stressful things that this woman has to do. It's very moving. But you can actually also have kindness which is a little bit absent-minded. So together with kindness, we're hearing the importance of attentiveness, and that is actually that deep listening, what is really going on here, rather than just the giving of kindness. It's listening as well, or being attentive to a situation, which is what that physiotherapist demonstrated. Thirdly is empowerment, and again, this is not new, but is all too frequent in our stories, where patients and carers are not accorded the potential for working in partnership that they would like. And then the last 2 go together, which is obviously the importance of what we've called organisational competence, and what Graham talked about, which is functional administrative systems. So a reliable organisations just are so important. And finally, not just reliable organisations, but healthcare professionals giving care that inspire trust and confidence that they kind of know what they're doing clinically. So it's all of those together. Next slide, and then we'll jump back. Thank you. So this is just a list of references for those of you who would like to delve into a little bit more depth into some of what I've been mentioning. But can we now go back 2 slides, and I'll hand over to Jeremy about the experience of asking and listening. So over to Jeremy now.
Thank you very much, Naomi, and it's been a pleasure to collaborate with Naomi on this project, and we bring kind of complementary backgrounds and experiences to bear. Naomi's academic experience and mine working in the field of patient and public voice. What I want to do is just to give you a few reflections on the process of finding and listening to patients and their stories. I've actually learned something about listening, and I thought I might have known quite a lot about it given my involvement in patient and public voice, but this project has given me some new insights, which I think are also relevant to the question about how you achieve culture change in healthcare. I want to start by just saying something about how we found the storytellers. It was relatively easy to find a diverse range of people in terms of gender and ethnicity. We worried about that at the outset, but in fact we got quite a good mix on those dimensions. We found it was harder to find people who were not in some way part of or connected to a middle-class professional circle of one kind or another, particularly that in relation to healthcare. And it was partly because we used our networks, we used our contacts within the health service and the available networks to find people, and they tend to have a built-in bias towards people who are connected to professional circles. So we had to try harder to fight against that to ensure a sufficient diversity of people. The hardest thing of all, paradoxically, was to find people who were not already in some way engaged in the healthcare system as patient activists or engaged patients or peer supporters or other people who had a structured role in relation to bringing the patient or public voice into healthcare. And it led us to reflect quite a lot on what it might take to reach out and find people who are not already engaged. And I think there are lessons there for all those in the health service who are feeling that they need to reach out to a more diverse range of people to get insight and voice into their decision making. So a second point was is about, as it says on the slide, people spoke freely to us, and it was kind of surprising how easy it was for people to talk to us and how generous they were with their time, and it really brought home the sense of an untapped resource amongst patients and carers, that they have their stories, they have their experiences, and if you create the right conditions, there is no barrier to them sharing those experiences with you. And as Naomi says, some of those are very moving and compelling accounts. We found that we worried at the outset that we would have to do all these face-to-face, and that if we were faced with the prospect of doing them over the phone, it would be much more difficult, and that would be a barrier to the free flow of information. That proved not to be the case. We've done a number of these interviews over the phone, and actually people speak freely despite the lack of visual cues. It seems to work really well. The notion of storytelling is interesting because some people do have a story to tell, and some people have told their story a number of times and to some extent have honed and polished it, and the act of telling their story is integral to their identity as an engaged patient, particularly somebody who is now involved in helping to improve services in one way or another. But not everybody has a story to tell. Some people have experiences that need to be drawn out through a process of interview. and through careful listening and careful questioning. And it occurred to me during that process that there is a real danger that in listening to somebody else's story, you end up imposing your own agenda and your own story. So where a person doesn't have a pre-existing story, you have to do justice to their experience and be really careful about how you listen. Otherwise, particularly in the process of recording and then sifting and then editing and fitting the narrative into your book, you are in great danger of not doing justice to that story or distorting it to reflect your own unconscious biases. We found that not everybody is equally interesting, and this is something that probably doesn't come up very much in the conversations about patient stories and listening to people, but some people are just inherently more interesting and compelling than others. And yet, some of the people who are less interesting and compelling also have really important insights and things to share. And so one of my reflections was that we often are aware of the danger of health service practitioners and planners and commissioners being at risk of being distorted by the powerful voices, the loud voices, and that the seldom heard voices get missed out. We often think about seldom heard in terms of demographic characteristics. So people of certain racial groups or people from certain deprived backgrounds are less likely to have their voice heard. But I think there's another dimension to that, which is that there is a danger that one becomes overswayed by the compelling and articulate and eloquent, and actually don't do justice to the experience and insights of people who are maybe not articulate, maybe not so good at telling a story, but still have a very important set of insights to share. And it was very important for us that we did equal justice to all the stories, regardless of the quality of the storytelling, if you like. It was a real liberation to be able to listen to people without taking notes. That's because we were recording people and we could sit down face-to-face where we were doing a face-to-face interview and really listen, really make eye contact and not be distracted by taking notes or clacking into a computer and typing things away. In fact, one of our interviewees commented on how nice it was and how contrasting it was to be able to talk in this way to somebody who's listening and making eye contact, in contrast with healthcare professionals often distracted by their computer screen and clacking away and anxious to capture and record, but maybe not really listening. So that was a bit of an insight into the difficulties of really listening in a healthcare context, and that, in a sense, the privilege that we had at the time we had to be able to sit down with people and actively listen without distraction. Even more liberating than not having to have props by way of taking notes and so forth was the fact that we actually didn't really need to do anything in the light of the stories that we were hearing. Obviously, we do have to do something with the stories in terms of turning them into a narrative that provides useful text in our book. But at the time we were listening, we were under no compulsion to do anything with the material we were hearing. So that's another way which I think our listening contrasted with the listening that often takes place in the healthcare context, where there is time pressure and where the listening is instrumental to the extent that people are listening in order to do something. They're taking a history, they're doing a diagnosis, they're dealing with an angry patient who's making a complaint, they're trying to solve a problem. So often in a healthcare context, in a very busy and hard-pressed environment, a lot of the mental energy is going into what am I going to do with what I'm hearing? Can I do anything with what I'm hearing? Rather than simply listening. So my reflection is that we were able to do very good quality listening because we had the time and we weren't under pressure to do something. The implications for the NHS in terms of culture change is that it is really important for organisations and teams to find ways of carving out time where people can listen without distraction and without feeling they have to impose their agenda on what they're hearing. But that is very, very difficult to do, and it relates very strongly, I think, to some of the challenges that Graham set out earlier. So the content of what we heard has been absolutely fascinating, and I hope we do justice to it in our book. But the process of listening to patient stories and reflecting on in what way they are stories in itself has been very, very interesting. I hope I've done some justice to the learning we've got from that. And I think there are implications which we also try and draw out in the book in the process of listening, which are relevant to how to do good listening and act in the light of that listening in real healthcare settings. Thank you.
So thank you, Naomi and Jeremy, for insights in terms of the importance of stories and where they come from in understanding the challenges of culture change in the NHS. Next, we explore the challenge of initiating culture change on a national scale. And in order to help us with that enormous challenge, we have, I'm delighted to say, Suzie Bailey, who's Director of Leadership and Organisation Development at the King's Fund. Suzie, welcome.
Thank you, Michael. We've just heard from Naomi and Jeremy about the importance of storytelling in cultural change. And I want to tell some of my story, but not only my story, but of the many people that I've worked with as I was working with colleagues at a national level to try and embark on a programme of cultural change to support NHS organisations in this endeavour. The reason I chose the title, Go to the Dark Side, was because this is the reaction that I got from all of my colleagues. At the time, I was working as a service improvement director at Sheffield Teaching Hospitals, and when I said I was going to work for the regulator, they all accused me of going to the dark side. At the time, as a service improvement director, I was working on some of the things that Graham talked about, which is trying to build capability and capacity for improvement, and doing that working with staff, patients and communities. And whilst I was really enjoying doing that and we were making some progress, it seemed to me that national organisations were not paying attention to or supporting what it really takes to make cultural change happen and to provide the environment in which continuous quality improvement can take place. So in February 2014, I found myself in a new role, a brand new role at the regulator, Monitor. I was in the policy department, and Monitor was one of the regulators at the time in the NHS, and it did exactly what it says on the tin. Its role was for authorising and monitoring NHS foundation trusts. I won't go into the difference between what's a foundation trust and what's an NHS trust, but around the time there were about 147 organisations that this organisation was responsible for regulating, and it was there to ensure that they were both financially stable, sustainable, that they were well led, and that they were locally accountable. This means that Monitor was actually independent of government in terms of its regulatory decisions, but it was actually accountable to Parliament and then the Department of Health, which is now the Department of Health and Social Care, for the performance and value for money in those 147 organisations. So Monitor at the time, my experience was that they had a relatively hands-off approach to the performance management of those foundation trusts. There was a sense and a term often used which was around earned autonomy. In other words, local leadership of those organisations had primacy, and Monitor would only intervene if there had been a breach, a regulatory breach. And the reason that I chose this stormtrooper photograph is that, again, that was a term that was often used both internally and externally, that if you found yourself in breach of the regulatory requirements, that the stormtroopers would be sent in. So the regulatory force would come in to both try and help the situation locally. And so there was that was the kind of tension that actually the regulatory approach was very interventional and perhaps didn't provide the support that local organisations needed. Looking back, in order to prepare for this presentation, I came across some evidence that had been given to the Public Accounts Committee at the time. And this was not evidence that I was familiar with when I was working in the policy department at Monitor. And what it concluded around the same time that I was joining the organisation was that many of the organisations in the NHS that were struggling had actually been allowed to struggle for far too long. And they've been in breach of the regulatory conditions for too long. And what that means at the end of the day is that patients are not receiving the high quality of care that they should. It also means that staff are not necessarily getting the support they need in order to do a really good job. So it was evident to the Department of Health at the time, and also to Parliament, that not the right type of support was being given to NHS organisations. Now, trusts get into difficulty for a number of reasons that are well documented, and Graham talked earlier about the failings in Mid Staffordshire, which are probably one of the most memorable inquiries into failings in the NHS. And these failings are as a result of many things, including local leadership, but also including things that are happening in the local health economy that have perhaps gone on unaddressed for some time. So intervening and finding the right way to support organisations to help turn around and improve care for patients, local communities, and improve conditions for staff was both something that was difficult for the regulator to know how best to do, and also was very labour intensive. And the thing that was really struck me when I joined Monitor was that I was one of a very small number of people in the organisation that had ever worked in the NHS. So actually looking at the skill set of what it is that national organisations need to have in order to deeply listen and understand the issues and then be able to offer support was clearly something that Monitor as a regulator was grappling with. And it was something that it started to tackle in 2014. The reports on this slide show just some of the national inquiries that had happened at the time, some of the policy documents which Graham referred to, and they all recommended in some form or other the need for cultural change. The 5-year forward view, which was also published in 2014, outlined how NHS services needed to change. The Mid Staffordshire inquiry, Graham has also referred to earlier. The Keogh review, which was a review by Bruce Keogh at the time, looked at the quality of care and treatment in 14 hospital trusts and recommended that they needed intensive support, and that's what happened following that. And the report from Don Berwick was commissioned by Jeremy Hunt, the then Secretary of State for Health, as a result of the Mid-Staffs inquiry. And in that report, Berwick made the point that culture will trump rules, standards and control strategies every single time. And it achieves to achieve a vastly safer NHS, it will depend on major cultural change rather than a new regulatory regime. But as Graham has highlighted in his talk, actually that requires both policy and practice. So the other picture on this slide is of a park. And around this time, I was introduced to Michael West, who's the chair of today's session. He was introduced to me by Chris Ham, who was then the chief executive of the King's Fund. Michael and I arranged to meet in a well-known coffee chain in the same city where we both live, in Sheffield. And because it was a dry day, we took our drinks across to the park opposite, which is called Weston Park. And on a walk and talk through this park, Michael and I talked about culture. We talked about the NHS, our experiences and our work, and in Michael's case, his many years of research, our passion to try and support cultural change. And we started to wonder if it might be possible to do something different. What might a work programme involving the regulator look like on culture in the NHS? And how might we learn with the NHS what it actually takes to make cultural change happen and improve care for patients and communities? I just want to give a bit of local history, which is the statue that you see in this picture is of Ebenezer Elliott, who died in 1849. He was an English poet known as the Corn Law Rhymer for his lead in the fight to repeal the Corn Laws, which at the time were producing hardship and starvation amongst the poor. He was a nonconformist, and he was an iron and steel merchant, and as you'll know, Sheffield is a city famous for its steel. He hated injustice, and he had a particular interest in the condition of the working man. It seemed to me in later years quite apt that the walk in the park that Michael and I had that day was the catalyst for a large programme of cultural change to improve the working lives of staff and in turn improve the conditions for patients and improve care in a programme that now is being used by over 90 NHS organisations in the NHS. So as a NHS leader, I cannot overstate the importance of the research and evidence base in order to build the business case to get this work done. trying to persuade a regulator of the need to work on cultural change was not the difficult bit. Working out what we might do to make cultural change happen and how we might support leaders in the NHS to make it happen was the really hard thing. And it relied on me having data and evidence to do that. Now, in my day-to-day work previously as an NHS manager, I probably hadn't used evidence in this way, in quite the same way. So actually working really closely with Michael, understanding what the evidence base was really critical. And I think the research that's the photograph in the middle, which is some of the groundbreaking work led by Mary Dixon Woods, now at Cambridge University, and others, on culture and behaviour in the English NHS, and the information and evidence that gave became a really powerful way in which we could influence the executive team and the board at Monitor to want to go on this journey. The lived experience of staff, work-related stress, the levels of bullying and harassment, especially experience of Black and minority ethnic staff in the NHS, were all important data to also bring to the table. I was really pleased to say that actually the executive team at the time understood that we needed to do something differently. They just weren't sure what that was. And what we committed to from a very early stage was the need to work with partners in the NHS. So not to do what Graham described earlier as the top-down onto the NHS thing, which would be typical of a stormtrooper regulatory approach. I'm pleased to say that at the time, the then Chief Executive, David Bennett, said that this was the most important work that we could be doing as a regulator to work on culture. He recognised that the traditional ways of trying to intervene weren't necessarily having the impact and the outcomes that were required. But I think fundamentally, and this is an important point that still stands today, is that it's not enough to just work on culture at a local level. It's not enough to support local organisations, however important, to be able to do that cultural work locally. But it is also critical that national organisations, including the arm's length bodies, including the Department of Health and Social Care, also go on this cultural change journey, understand what it takes to change their own cultures, because they are part and parcel of the culture that we have in the English NHS. And so we continue to draw on the available evidence base in order to further work on culture and leadership in England, including looking at global studies. And colleagues at Manchester and Birmingham universities have recently finished an evaluation of the Culture and Leadership Programme and its progress to date. And we're looking forward to seeing those results and the recommendations that research and evaluation will make in order to move this work further forward. So I hope I've conveyed in my story so far the importance of both policy and practice. We need to be able to do the two together. And on this slide, I've just tried to capture some of the key steps that we have taken to date in making this happen. When you look at them on a single slide as a series of bullet points, it makes it look so easy. And yet, the hard work of staff and patients in actually making these changes in the over 90 organisations that are doing this work cannot be understated. And so although I'm going to try and summarise what those steps are for the purposes of this presentation, please understand the thousands of staff and patients who have contributed to the work that sit behind this slide. So first of all, as I said, we needed to understand and use the research, and I'm very grateful to those who are involved in that research for the evidence base that it produced. We needed to develop the case for change, and importantly, we needed investment, and that was not just staff, that was also money. So how would we support a national programme of work on cultural change? As I've said already, we needed to persuade the board of Monitor, and we needed to persuade the executive team that this was worthwhile doing, and we also needed their commitment and their sponsorship and role modelling for this work. We needed to create a team within Monitor to actually make this work happen. And as I say, I was sitting within the policy team, and it was important that we actually had a look across Monitor to see how we could create a project team that could support and underpin the work. And we also needed to commission a credible partner, because as I've previously said, we weren't very good at knowing how to support organisations with cultural change. And so we needed to work with external partners in order to do this. And I'm pleased to say that we were able to commission the King's Fund and Michael West to work with us. And so we formed a single team of the King's Fund and colleagues at Monitor, and also colleagues at CCL. The next bullet point is around the partners to co-produce the work. And on this slide, I have the three pilot organisations, pilot trusts that worked with us. They were absolutely critical in the design, the testing, the learning for this work and the catalyst for what has followed. We are incredibly grateful to the leaders in those organisations for sharing with us where they were at in their cultural journey, for sharing both the light spots about what was going well in their organisation, but also the dark spots, and their commitment, all three of them, to actually involving patients and communities in their cultural change work. And that was a key reason for why we actually selected them. And they formed part of that creating the team. So we didn't have a team that sat at the centre and then a separate team that went out and worked with the trusts. We formed a single team together. And I think the time that the leaders, particularly some of the executive leaders in those three pilot trusts, gave us was an incredible commitment, actually, because they were with us all the way. And even though some of them have now moved on to roles elsewhere in the NHS, they continue to be connected and share their learning from this work. So finally, and not really finally, I want to come on to the role of other organisations in this journey. So I started my presentation talking about my own journey and how through that I have worked with so many people who are passionate about making improvements in their local services, passionate about their role in cultural change. And at the end of the day, what we were trying to do with this programme was to help leaders, managers, teams in the NHS understand that cultural change is possible, that they all have agency to help with this, that it isn't something that you need to wait for someone else to do on your behalf, that you need to create a change team within these organisations to actually do the work locally. But what is also important, as I said earlier, is that the national organisations involved in health and care systems also are committed to their role in cultural change, their role modelling, the work that they do to reform their organisations. And this slide represents the 13 national organisations who work together to develop the national framework for leadership development and improvement, which is called Developing People Improving Care. And you can imagine the relational work that went on then and is still going on in order to make sure that there are effective partnerings between the organisations represented on this slide. And these aren't the only national organisations that are involved in this work, they just happen to be the 13 at that moment in time that were working on this. Improving culture in the NHS requires the role of all of these organisations and in the remits and the influence they have on national, regional and local systems. It fundamentally requires all of these organisations to have a strategic commitment, an organisational mission, as was being referenced earlier, to the engagement and co-production with staff, with patients and communities to support cultural change and to sustain improvements. Finally, I think I've just mentioned the people plan that is due to be published later this year. And the interim people plan for England makes it clear that creating a better leadership culture is really critical, including how to make the NHS the best place to work for staff. The experience of the pandemic shows that we still have a long way to go in order to make that the possibility and the reality for our staff. However, I am confident that if we all commit within the influence that we each have and the roles that we each have, it is possible to make cultural change happen and therefore to make improvements for the patients that Naomi and Jeremy spoke about. And I guess finally, I would just conclude that as a leader who started life out as a very junior admin assistant in the NHS, I have learned the value of research and data to my work, both when I was an operational manager, but increasingly as I've worked in a national role. We really need the work that researchers do, the data that you provide in order to propel and develop our work further. Thank you very much.
So thank you, Suzie, very much for that whistle-stop tour through the enormous cultural leadership programme. Speaking personally, it's been just the most enormous privilege for me to have been involved in that and to have interacted with so many staff from so many organisations who are inspiring examples of what our health service is all about. Thank you for all three of those presentations. We now have a little time to ask our very experienced group of presenters some questions briefly about about how their insights can help us understand some of the challenges we face during the dark times of the pandemic. Thank you very much for the presentations, and I'm very aware that this conversation is taking place as we are still in the middle of an epidemic in the UK, a pandemic worldwide. And I think there are important lessons to be learned from your research, but also perhaps important lessons for us to learn from what's happened during this period. And Graham, I want to come to you first and to, I guess, reflect on the fact that during this period, there's been quite enormous change. Just in the space of 3 or 4 months, we've seen a real intensity of focus on how to respond to the pandemic. We've seen a blurring of professional boundaries and hierarchical boundaries, some loosening of the constraints of the national regulatory bodies, actually some changes in the way teams have been working and so on. And I guess my question is, well, actually, I want to say that above all, what we've seen is the most extraordinarily jaw-dropping levels of innovation and scale of innovation in responding to the crisis. And I guess it's what's enabled such profound culture change, would you say? You know, what 2 or 3 things would you pick out as really having enabled this change to occur?
Yeah, thanks, Michael. I think, I guess the first thing I'd do is to perhaps sound a note of caution as to whether we can necessarily call this cultural change. So, I mean, you know, there's certainly been a lot of changes. There's been a lot of invention because of necessity, if you like. So, you know, something that changes in the external environment so rapidly requires a very rapid response. And there's no doubt that the system as a whole has been, you know, hugely responsive to that. As you say, hugely innovative in responding to it. And, you know, that applies across the whole system. Lots of individuals working together in unprecedented ways, breaking down hierarchies, breaking down team boundaries and all the rest of it. So I think, you know, partly it's necessity is the mother of invention, but that it doesn't necessarily follow that invention will always happen as a result of that. So we should definitely give credit where it's due and say, wow, fantastic, so much good stuff going on. To come back to the point about culture change, we shall see how long it lasts. And I think there's probably important learning to be had about what the conditions are that have allowed that change to take place. So there's learning about the new innovations themselves, but there's also learning about the conditions, the relationships, the structures that have enabled that to happen and what should be sustained for the medium and long term. And I think there are also important questions about the potential unintended consequences, because there's no way that all of that bureaucracy is unnecessary. You know, I made a point of stressing the importance of good administration in my presentation, and there are definitely potential downsides to innovation. So I think I'd make 2 further points in particular. One is the need to learn from the process, but related to that also to monitor the outcomes, to see what the results have been in terms of outcomes of staff, outcomes for patients, outcomes for the system, and to pay heed to the unintended, potentially negative outcomes of that as well. So we need to learn both from what's already happened, but also to continue to be reflective and reflexive about this, to evaluate as it goes on. And then the second and final point that I'd make, I guess it comes back again to one of the points of my presentation about the burden that COVID-19 has placed on already stressed, already pressured staff. And that's both in terms of the size of extra work, you know, the scale of the response, the potential for burnout, the stress and the horror, actually, of the situation that a lot of staff have faced. But I think it also relates to the potentially differential impacts of that across different staff groups, across different socio-demographic groups as well. And I think we do have to be mindful about the fact that that staff goodwill is not a well that is indefinite. It can be depleted, and we need to ensure that in demanding more of staff, first of all, we recognise that can't go on forever, and second of all, that we attend to the impacts of that on individuals, on different groups, and that we try to ensure that there is protection and support in place for those staff groups.
Yeah, So thank you. And I think a couple of points just to emphasize is that stress levels were already at their highest amongst NHS staff before this pandemic arrived. We were already in a situation where the way we were working was unsustainable. So the need for culture change is enormously important. And I think the second reflection in response to your question is the discrimination against BME staff within our health service, which mirrors that in society, has been endemic for the history of the health service, really. And one of the challenges, I think, for those who are watching this this video of discussions about culture change is how we change a culture across, how we change the cultures across the NHS, so that we address the issue of discrimination and structural discrimination and interpersonal discrimination. I think that's a challenge as researchers we must step up to. So the second question really relates to your answer, Graham, and I want to ask Naomi and Jeremy. I've had conversations over recent days with senior staff in NHS trusts who have been just delighted by how they've been able to respond and in very difficult circumstances, and they've expressed what an enormous contribution staff have made, and that many of the constraints have disappeared. There have been new ways of working, and somebody said to me, well, how do we stop ourselves just slipping back into the glue of the old ways? And we've just described how we'd already reached a situation where it was unsustainable. So is there anything that we as researchers in culture can offer about how we avoid slipping back into the glue as this person?
Shall I start off and then hand over to Jeremy? And I think relating to our presentation around listening to patients, I think if staff and trusts can always ask themselves, okay, we stopped doing that because we couldn't during the pandemic. When we go back to some kind of new normal, let's make sure that we do things in a way which only adds value to patients. So one concrete example would be, outpatients and outpatient follow-ups, and understanding what worked better actually during the pandemic and what worked better for patients, and therefore not slipping back to old ways. So asking themselves, but then we would also say ask patients routinely, just almost as part of the communication, how was that for you? And how was this way of working for you? So making sure that you add value for patients and not do anything that doesn't, or in fact detracts from value for patients. And then the final thing I would say is, at the core of all of this, we do talk quite a lot about listening to frontline staff and the importance of that in well-run organisations, but there's also an awful lot of lay wisdom that we can tap into, that we need to tap into. So that's in summary what I would offer.
Thank you, Naomi. Jeremy?
Yes, a few thoughts. First of all, what COVID has demonstrated is the amazing changes that can be made when there's a very strong sense of common purpose. So one thing for me would be, how do you maintain that sense of common purpose when it comes to making necessary changes and improvements to local healthcare systems, and making that a collaboration between the managers, the clinicians, and the patients and communities. So let's hang on to that. Let's also recognise that one of the things that happened during the pandemic is the NHS made huge changes, but so did the public. The public stepped up to the plate, and the management of the crisis was only possible because of a collaboration between the professionals and the public. So let's hang on to that sense of partnership too, and actually do something to tackle what Graham earlier talked about as the continuing and rather perplexing marginality of patients and carers and communities in a world where patients are supposed to be at the heart of everything, but often aren't. Two other quick things. COVID has really highlighted health inequalities, both in terms of demography and age and race and poverty. And of course, we've worried about those issues for a long time, but I think the health and care system has not done enough to tackle inequality and discrimination. and recognise the importance of social and economic determinants of health. And maybe COVID is going to be finally the wake-up calls to taking those issues much more seriously. And that inequality plays out in all kinds of ways. You know, we are speaking in the wake of the George Floyd incident and all the protests about racism in America. We're an all-white panel of experts. So, you know, we've still got a lot of work to do on race and other forms of inequality. And then finally, let's hang on to the possibility of digital ways of working. The NHS has suddenly discovered the possibility of online consultations and digital engagement with patients and communities. Let's not go back to the old ways when there are so many better ways. I think COVID has expanded the range of what we think is understand to be possible in relation to online. We've all been on a very steep learning curve, and in many ways, I think that although it has its problems, it's been a good thing. So let's hang on to that too. Thank
you, Jeremy. Yeah, and the steep learning curve has been not least for the people on this panel today in grappling with presenting at a conference in digital format. I think the points about listening to patients and involving patients and communities in the genuine co-design and co-ownership of our health services is fundamentally important. And of course, the issues of Black, Asian and other minority ethnic group staff within the health service. And there are good case studies around. We see, for example, in terms of how to address the issue of discrimination within NHS organisations, North East London Foundation Trust has provided a great example of how to systematically, comprehensively and persistently address the issue with really positive consequences. And we see examples in this country of genuinely involving the community in the co-design and delivery of services, Healthy Wigan, for example, and plenty of examples abroad, the NUCA system in Alaska, the Montefiore system in New York, what's happened in Christchurch in New Zealand. So great examples. And if one place can do it, we can adapt and all learn from that. So Suzie, there were dark times before, very dark times before the pandemic, and then they've been even darker since. And I guess the question that I have is, any thoughts that you may have about what might be the kind of key cultural elements of a more enlightened health and care system in the future?
Well, I think two key elements have just been talked about, which is fundamentally the partnership with the public and communities around making change happen. The other is tackling inequalities. So I won't focus on those. The one that I would really want to focus on is the health and well-being of staff employed in the NHS and in social care. I think one of the good things to come out of the pandemic is people valuing key workers, regardless of the role they have, regardless of where they are in the hierarchy of these organisations. And the stories that we've heard of staff, both staff in very difficult circumstances and without the protective equipment they need, but also really amazing stories of how people have teamed together, how they've found solutions, created innovations. So I think the thing we really need to pay much more attention to and see action on at a national, regional and local level is about how to sustain improvements for the health and well-being of staff, particularly around the voice and influence of staff. So how do we flatten the hierarchies? How do we open our health and care systems up to truly listen to all voices? And that means tackling inequality that has just been talked about, particularly for Black and ethnic minority staff. And we also fundamentally need to tackle work overload. You know, it's very, I'm a operational manager by background in the NHS, and, you know, busy workloads, heavy workloads are kind of seen as the norm. And that can't be right, because that places undue pressure on teams and means they can't do their best. So we need to find better ways of actually understanding those workloads, addressing them, helping teams to do a number of things, some of which is around quality improvement, improving processes, but is kind of a more relentless focus on what it is that we're all busy doing to make sure that actually we can clear out unnecessary things and ensure that our staff can work on the right things, that they're equipped to work on the right things, and that actually we take some of that burden and that stress that the NHS staff survey shows us year after year. we're continuing to damage people. So whilst there's been amazing love for NHS staff and social care staff during the pandemic, we need to do something with that love, and we actually need to make sure that we have a renewed commitment and that the health and well-being of staff comes right up the national agenda. Because I have to say, in my experience of working in a national organisation, it certainly hasn't been the priority over finance. So that's probably the kind of area that I would most like to see us focus on.
No, it's really helpful, Susie. Thank you. I mean, I think chronic excessive workload has become the pattern in the wallpaper that we no longer see, yet it's the #1 predictor of staff stress, staff intention to quit, patient dissatisfaction, error rates, and if we don't address it, then we're not addressing the fundamental problem within our health and social care services. And that's about a whole range of issues that we've touched on today, to do with staffing, technologies, patient and community involvement, team working, and so on. So I want to thank, on the behalf of all of those who are watching this webcast from HSRUK, our presenters today, and also to leave, I think, with a message for all of the researchers watching, which is that I think particularly during these dark times, it's really important as researchers that we reflect on our role and the contribution that we can make, that we're not here just to benefit ourselves as researchers, but to make a contribution to our health and social care services across the UK. And I think there's something really important about reflecting on our roles, ensuring we have a vision of what it is we want to make, of how we want to make a difference, ensuring that we bring compassion to our work. That's the core value of health and social care services. And I think in our work, we should reflect that value. And thirdly, I think it's really important to have the courage to pursue our research in order to make a difference and ensure high quality, compassionate and continually improving care for patients, and ensure high quality, continually improving and compassionate support for the staff who deliver care. So thank you all for joining us. And again, thank you to our presenters. Take care, stay safe and well.
Thank you.